I'd like to discuss Mr. H in Clinic Room 3 with you. He's a 55-year-old Caucasian male with history of hypertension and smoking. He's complaining of intermittent chest pain that started 6 days ago, and his last episode was 3 hours prior to coming into clinic today. He's not currently having that pain, but he is concerned, wanted to be seen urgently, and he's accompanied by his wife. He states that he is a generally well male and that he has no other decline in his current state of health. With regards to the episodes, the first started 6 days ago while he was mowing the lawn around 5 p.m. and it then reoccurred this morning at 10 a.m. while he was walking his dog. Both episodes were identical. It has a sudden onset, lasts about 10 minutes, then takes about 10 minutes to gradually resolve. He says it's a left-sided anterior chest pain, no radiation to the arm, back, or neck. He states that it's a burning, nagging, non-debilitating pain and that it's 5 out of 10 on a pain scale. He recognizes that it is exertion-related. It occurred twice with activity and resolved both times with rest. He says that the episodes last 20 minutes in total both times, and that there are no other associated symptoms he noticed. So no shortness of breath, fatigue, dizziness, numbness, tingling, or cough. He does state he had anxiety with the episode, but states it could be just fear of cause. He tried Pepto-Bismol after the first episode, just assuming that it was heartburn or indigestion. It provided no relief. He stated both times the pain resolved with rest. Up until 6 days ago, he has never experienced these symptoms before. With regards to his history, he was diagnosed with hypertension in 2015 and has been a smoker for 35 years, roughly 1 pack every 2 days. He has a Newfoundland diet, high salt, high fat intake. His mother had a heart attack at 65. She is living. Otherwise, he has a family history of dyslipidemia. He denies having any recent fevers or infections, no recent international travel. He denies any sharp or centralized chest pain, and he has no recent trauma or history of blood clots. And he denies IV or illicit drug usage. He's being monitored by Dr. Fisher for cardiovascular risk and hypertension management. He takes 1 home medication, hydrochlorothiazide 25 daily. He has no allergies, states that he's a moderately active man. He works full-time as a linesman, and he has no GI issues that he's noticed, no issues eating, digesting, and he has normal bowel movements. So I assessed him and found that he appears well, he's calm, he seems comfortable, he's non-toxic looking, he's non-diaphoretic, he's got a good overall pink color. His vitals are near his baseline, but I noticed his blood pressure at the moment is about 10% higher than what I can find in documented in Meditech. So at the moment he's afebrile. His BMI is quite high at 33, so class 1 obesity, high risk. In Meditech, I found that he had a lipid profile done 12 months ago. It was normal but borderline high. His LDL was 3.5 and apolipoprotein B was 1.1. A1C at the time was 5. So cardiac-wise, his ECG looked normal to me. He's normal sinus rhythm, no bundle, no blocks. His STs were not elevated or depressed. His pulses are 2+ throughout, no edema present. His JVP is less than 3. His cap refill is less than 3, and he has no clubbing. I didn't note any lymphedema. His limbs are normal temp, nice and pink. His calves are non-remarkable and equal bilaterally. He has no carotid bruit. His S1, S2 is normal, and he has no noted murmurs. He doesn't report any pain on deep inspiration or coughing. I didn't detect any friction rubs. His chest and pectoral muscles are non-tender. Chest expansion is symmetric. No retractions, no lag. Breath sounds are clear bilaterally. No increased work of breathing. He has an obese abdomen, but it is soft. Bowel sounds are present in 4 quadrants. I didn't detect any increased aortic pulsations. His liver is normal size, no splenomegaly, none tender. There's no rebound tenderness. Murphy's sign is negative. I did check his left shoulder and arm just in case. He has good range of motion, no weakness, no joint effusions. His muscle strength is 5 throughout, and his Apley scratch and near impingement was negative. So overall, given his medical history and his cardiovascular risk, I think that angina pectoris could explain his symptoms at the moment and that it's likely coronary artery disease. I would like to rule out NSTEMI and STEMI as well as angina, as well as Prinzmetal angina. No other abnormalities have led me to believe it's referred pain or infection, but given the situation and the concerning symptom, I did ask him to stick around in the clinic room for you to see him, and together afterwards we can decide on a plan and what investigations we'd like to start with.